Thank you for still being here. I will talk to you about researching the first 10 years of lives of children that are born with a congenital anomaly. I will first of all introduce EUROLInkcat to you, why we exist, what we do, and then I will switch to the Horizon 2020 study. This is something that we have to always declare. I have nothing to declare. In the late 50s, there was all of a sudden quite a number of children born with limb defects, reduction defects, and up to then this congenital anomaly was really rare. So it was typical that all of a sudden there was a lot of children born with missing parts of their arms, sometimes hands attached to shoulders, and it was on quite a big scale. It took quite a long time to find out that there was a common thing in the pregnancies of all these mothers, and they used the drug Softenon. It was meant to be safe in pregnancy, and it was supposed to help for sleeping problems, and it was supposed to help for something that most pregnant women have. They have pregnancy-related nausea. So it was used on a big scale, and this is why these children could, this is why the effect was big. That was the reason to start a European registry to monitor every born child with a congenital anomaly and to find out if these anomalies are being stable, if their trends or clusters would occur. And for the Dutch situation, it meant that we started in 1981 and we were funded by the Dutch government. And we cover the north of Holland. So we only cover Groningen, Friesland and Drenthe. And we register children with congenital anomalies. This is about 300 to 600 children a year. And I have to say that it's not only live-born children, because it's, in fact, to be more precise, it's every pregnancy that concerns a congenital anomaly. So it can also be about a terminated pregnancy. We need permission for registering the children, so we ask permission from the parents. And if they do give permission, they get a questionnaire, and this is a long questionnaire. It's 18 pages, and it has all sorts of questions about the pregnancy, the time of the conception, what the mother was doing, what the father was doing, whether they took drugs or not, or whether they smoked or were on medication. So we collect a lot of data that could be of any influence on the anomaly of the child. We are part of a global monitoring network, and it's called the ICBDSR, and we are, let's say, the Dutch department. The whole EUROLInkcat registry has many registries in different countries. Some cover all of the country and some only parts. And what we do is that we collect data in the same way, and we also code the data in the same way, meaning that we can pool data and do good research, because we can have higher numbers of anomalies. Some anomalies are very rare, so it's nice that you can pool data and have a more and bigger data set. This is what we have been doing always anyhow. So that was the start. And then we figured, if we are doing this for a long time and we have good quality data on congenital anomalies in Europe, wouldn't it be good to check what happens in the first 10 years of life? Is it different if you are born with, let's say, a cleft palate in Portugal or in England? Does it matter? Does it matter how much you are operated, how long you're in a hospital, whether you go to a normal school or not? We had a lot of questions about, let's say, the follow-up of these kids, because we don't have that. We only have the information about what kind of anomaly is it, and are they live-born or not, that type of data we have. But we don't have the follow-up. So how do we find out? We thought it must be a good idea to look at the live births in all the EUROLInkcat registries in Europe, and first start just look in death certificates. See if these children are still alive. Maybe they are, but some probably are not. Let's have a look at hospital records. Do they have surgery? And if you are born with a certain anomaly, is there more surgery in a certain country compared to another? How about prescriptions? Are these kids on medication? And is it the same in every country? Or are there differences? Are there quality differences? And how about their educational needs? And then the thought was, if you do collect, if you are going to enrich the data that you already have, you have a large data set, you can do a lot of research. Should we involve parents to ask them, what do you want to know? What is really relevant to you? So this is the start of the project. We thought we should try to collect data and then we should involve parents and see what we're going to do with it. Why is it so important? We are talking about approximately 130,000 babies born in Europe every year, and they might have a small congenital anomaly, but it might be a big one as well, and it might be an anomaly that is, good to live with or very hard to live with. There's many anomalies that are rare, so we have a lot of rare anomalies, but only a few of each anomaly. And congenital anomalies are a major cause of infant mortality, morbidity, and also long-term disability. Apart from that, we know that survival of children is improved. If you look at mortality in European children, you see that there's a lot of variation in all different countries. Why is that? Is there like a best practice in some country? And if there is, could we implement this in other countries as well? If you look at mortality associated with congenital anomalies, you can see that congenital anomalies have a high impact on mortality. In some countries, nearly 40–50%. You have to keep in mind that it's not allowed in all countries to terminate pregnancies. So it's not of any... I mean, you can understand that Ireland and Malta are very on the right side of this figure. So there's a lot of difference and it contributes to mortality. Now, if survival is improving and their health is important, how do we find out how they are, how well they are? We have to link to data sets. That was the first start. Not every country has access to all data. The Scandinavian countries are relatively rich because they can connect to all sorts of data sets and push a button and everything drops down. But for other countries it's hard. So we said, okay, you can either choose to join a certain work package and see if you can collect the data for this. And so in fact this is more or less how it's going to, what it's going to look like. If we do link, you cannot release data from a certain country to like some central place. So we said, if we can't release them, we should think of that and create pre-specified tables, and every participating country should fill in these tables and then maybe send the tables so that nobody knows who's in there. And that's what we are going to do. We make pre-specified tables and all countries are going to send their aggregated results to the central results repository. And from this central results, we will work out how about mortality in Europe, in different countries for every different anomaly. How about morbidity? How about data accuracy? Is it possible to implement best practices in other countries? And the work package education is a difficult one, but it's a good one to look at too. Is it possible to see why in one country a child can attend regular school and another country not? I've mentioned before that for setting the important questions, we will involve families. And the idea is to create an internet platform, an e-forum, so that parents and researchers can interact with each other and they can help setting research priorities. This is a difficult thing to work out, but it's good because if it after the project, this is something that can stay and that can maintain itself, and the data that are collected can be used for further research. If you want to have a look, I think every search machine, if you type in EUROlinkcat, you will get there. There's a lot to see, a lot to look at. And if you have any questions for me, you're welcome. That was within 10 minutes, right? Good. Yes, please.
So, what did you use for severity stratification? Because you address complex question and you address a very broad spectrum of diseases.
Yes.
So, some kind of severity stratification should be needed to have meaningful results in your analysis. Do you rely on patient, on parent-derived information? Or do you have some more from the medical records?
Yes, we have medical records, and we try to either ask parents, are they correct? Or ask parents, did you do anything else that's not in the medical records, and try to get this straightened out. And if there's any doubt, we don't have it in the data set. So we have medical records from hospitals, but we also have for the Dutch situation, which is quite, well, it's exceptional. We have data from the Dutch pharmacies as well, prescriptions that went in the pregnancy period to the mother. And then we asked the mother, did you actually use it or not? And if you did not, or did only half, then what did you do? So we try to be very precise on what happened. Yes.
For you,
yes.
You mentioned in one of your slides that you have that Europe has about 130,000 cases of congenital anomalies.
Yes.
And you described the pattern of your project.
Yeah.
How many cases do you expect to collect in this study, in this project?
That's a good question. We don't start to collect, we do it retrospective. So we'll have a look at children born between 1995 and 2015. And of these kids, we're going to try to find data in the next 10 years of their lives. Meaning the first ones born will be a full 10 years, but the latest will only be a few years.
Do you mean to say that you try to plan a cohort study that is like the generation are expanding in time? Do you track these kids born from the period up to, say, 2030?
We know exactly how many kids were born in this period, in which country, and which anomaly they have. What we don't know is what happened after that. So this is what we're going to try to find out. So we're going to connect to databases like hospital records or mortality databases and find out if they died 3 years, 4 years, or how many years after birth. But it's all retrospective.
Then I come to the question you were saying, I want to involve the parents.
Yes.
How are you going to do that? Are you going to try, because I cannot imagine that if you have that X number of cases in your study,
Yeah.
that you're going to ask an X number of parents.
No.
Probably much lower, right?
Yes. The project is divided in work groups, and there's a work packages. There's a work package working specifically on this, and they contact patient organizations, and most patient organizations have Facebook groups or internet fora, and then there's key, key holders is not the right word, but we try to find contact persons for a certain amount of anomalies that we are trying to set this up for.
That means that if you talk to parents, that they might not be directly connected to the data of.
Exactly. It might be just a parent with a child with an anomaly that's not specifically in our data set. It is meant to be that we have a big, large data set and we can do research on anomalies that other people might.
Basically, you have qualitative data that you try to interpret on a different way than the data sets that you have collected quantitatively, right?
No. If you look back, what happened to children with, for example, heart anomalies, and you see that there's a lot of difference between where you were raised and what kind of surgery you had, then we can learn, let's say, best practices for future. If there's parents that say, in my life with my child who also has a heart anomaly, what I find very difficult to deal with is this and that, and do you have a question, or do you have an answer on this question? We can try to look back or see if we can find this as well. So it's different questions maybe, but we try to involve them in getting answers out of the data set that we create.
Basically what you do is you have a set of data that you get from those parents, and you have still next to you the other sets that gives you a lot of information about the kids. Right?
Yeah, but we don't get new information from the parents. No, it's just.
In a way, to match what they say to the information that you have from them.
No, it's not. We're not matching. Yes, exactly. Yes, exactly. Yeah.
So about quantitative questions.
Yes. It's new questions. It's whatever is bothering you if you have a child with an anomaly X or Y.
Because they know better what to look into the data set. You don't always have enough imagination to imagine what to look for in this data set.
Well, they have like the real life questions, the things they struggle with, and we have the knowledge to search this data set and see if we can find anything that could help. So the parents are not going to do the research. Let's keep that clear. Yeah.
No, but the articulated questions.
Yes.
Yes, you articulate questions yourself too.
Exactly. Yeah. Yes. So we will start answering our own questions, and then involve parents and see that we can make this a continuous thing, so that we don't only collect data for now, for what we like to do, but make it future-proof. Yeah.
How do you see this project continuing after the end of the actual duration? You will create a very important standardized data set that would be useful. Do you see like countries adopting it and continue to?
I think the goal is that it's accessible for like anyone who wants to do research. It is open access, actually. You should make sure that once you have aggregated results, that if you want to look into it to find things out, then you should be able to do so.
And have continuous input for
Yes.
next children that are.
Yes. Yeah. Yeah. We'll try to get that fixed.
One issue, as you kind of alluded to, is that some people have collected some data and other people do not. Right?
Yes.
And what I expect too is that some people have collected similar data, but they're not identical, so they can't do the same analysis, or make the same table. Right?
Yeah.
And it could, I mean, I don't know if you looked at the heterogeneity, the differences between the different collection methods.
We do. We did at the start. We asked every registry, if you go to any mortality database, then what's the variables that you can draw out of that? So we first did an inventory. We started January 2017, so we took like a year to collect that sort of information. If everybody could do 3 out of the, let's say, 20 variables that exist, then at least we're going to look at those 3. Or we said ourselves, well, we should at least have this, that, and that. And if you can't do that, then maybe you shouldn't be in this work package. So this was a big puzzle, because it differs for each country. So that's a hard thing, yeah. But we have an overview now. It took some time, but it's,
I think
yeah.
one step further, but I'm sure you're thinking about it already, is recommendations about what to collect in the future.
Exactly. And also, we know already that not all data is all accurate. So if you want to do good research, you should have like a standardized way of coding and a way of, yeah, writing down what happens. And so we're gonna, I think this is gonna help as well. Not all countries have a congenital anomaly registry. So if you can help out saying you should monitor this and that and code it in this and that way, and then you can do this follow-up, like we did, we can help. We can help out.